about your genes or your DNA. Let's find the answers. Ask a genetic counselor.
Hey everybody! Welcome back to another episode of Ask a Genetic Counselor. I'm your host, licensed genetic counselor Sam Geere. Thanks so much to everyone who submitted questions after the first episode. I honestly wasn't sure what to expect when I launched this podcast, but it's been really fun seeing the questions that have come in. So, whatever brought you here, I'm glad you're here. And as always, questions are answered for educational purposes only and shouldn't be considered medical advice. So just know I can't provide personalized medical recommendations or interpret individual genetic test results. Now, let's jump into our first question. So, question 1 says, I'm an identical twin and I have Graves' disease. Does this mean my twin sister has it as well? This is a really interesting question. And honestly, I think identical twins are one of the reasons so many people become interested in genetics in the first place. If you stop and think about it, identical twins are pretty amazing. They start from a single fertilized egg that splits into 2 embryos. And because of that, identical twins generally share nearly all of their DNA. And when people hear that, they often assume something very logical. If we have the same DNA, shouldn't we have the same medical conditions? It sounds reasonable, but the reality is a little more complicated. And I think the answer tells us something important about how genetics actually works. So let's start with Graves' disease itself. Graves' disease is an autoimmune condition. An autoimmune condition occurs when the immune system, which is normally designed to protect us from infections and other threats, mistakenly attacks part of the body. In Graves' disease, the immune system produces antibodies that stimulate the thyroid gland. The thyroid then becomes overactive and produces too much thyroid hormone. And that can lead to symptoms like weight loss, anxiety, tremors, heat intolerance, heart palpitations, difficulty sleeping, and a variety of other symptoms. Now, one thing researchers have known for a long time is that Graves' disease does have a genetic component. We know this because it tends to occur more often in certain families. We also know it tends to occur more frequently among close biological relatives of someone who has the condition. And some specific genes appear to influence susceptibility. But, and this is a very important but, having a genetic component is not the same thing as being completely determined by genetics. In other words, Graves' disease is not typically caused by a single gene that guarantees someone will develop the condition. Instead, it appears to result from a combination of genetic and non-genetic factors. And that's where identical twins become incredibly interesting, because researchers have studied identical twins for many years. If genetics were the entire story, we would expect both twins to have Graves' disease whenever one twin had it. After all, they share essentially the same DNA. But that's not what researchers are seeing. Sometimes both twins develop Graves' disease, sometimes only one does. And that observation tells us something really important. It tells us that DNA matters, but DNA is not the whole story. Scientists often use a term called concordance when talking about twins. Concordance simply means both twins have the same condition. If one twin has Graves' disease and the other twin also has Graves' disease, we would call that concordant. If one twin has Graves' disease and the other does not, we would call that discordant. And what researchers have found is that identical twins can absolutely be discordant for autoimmune diseases. In other words, one twin may develop the condition while the other does not. And I think this surprises people because we tend to think of genetics as a blueprint. And that's not entirely wrong. Genes absolutely provide important instructions for how our bodies function. But imagine 2 people are given the same exact recipe, same ingredients, same instructions, same measurements. One person bakes the cake in one kitchen, the other person bakes the cake in a different kitchen. Maybe one oven runs hotter. Maybe one person leaves the cake in a little longer. Maybe the humidity is different. Maybe one ingredient was stored differently. Even though the recipe was identical, the final result may not be exactly the same. Now, obviously, human biology is much more complicated than baking a cake, but the basic idea is similar. Genes provide instructions. However, these instructions are constantly interacting with the environment. And when I say environment, I don't necessarily mean something dramatic. People hear the word environment and sometimes think I'm talking about pollution or toxic exposures. Those things can matter in some situations, but environment is much broader than that. It includes infections, stress, hormonal changes, immune system activity, nutrition, random biological events, and many things that scientists are still trying to understand. One thing that makes autoimmune diseases particularly fascinating is that we still don't fully understand why one person develops the disease while another person doesn't, even when they share a great deal of genetic similarity. In fact, if you've ever wondered why researchers are so interested in twins, this is one of the reasons. Twins help us understand the relationship between genes and everything else. Because if two people share nearly identical DNA but have different health outcomes, it suggests that something beyond the DNA is contributing to the story. Now, there is another concept that sometimes comes up in discussions about identical twins, and that's epigenetics. Epigenetics is a term that sounds much more complex than it really is, but the basic idea is actually pretty simple. So, remember how I said genes are like instructions? Well, not every instruction is being used all of the time. Different cells turn different genes on and off depending on what they need to do. So, think a skin cell behaves differently from a brain cell. A brain cell behaves differently from a muscle cell. They contain the same DNA, but they use that DNA differently. Now, epigenetics refers to some of the mechanisms that help regulate which genes are active and which are less active. And over time, identical twins can develop differences in those patterns. Again, this is an area of ongoing research, and we certainly can't explain every medical difference between twins using epigenetics alone, but it does help illustrate an important point. Even people with nearly identical DNA are not biological photocopies of one another. They're individuals. And that brings us back to the original question. If you have Graves' disease, does that automatically mean your identical twin has it? And the answer is no, not automatically. If your twin already has symptoms that are concerning for thyroid disease, it would certainly be reasonable for them to discuss that with their healthcare provider. And because Graves' disease has a genetic component, their risk may be higher than someone in the general population. But higher risk and certainty are not the same thing. And that's something you're going to hear me say a lot when we talk about genetics. A higher risk does not guarantee an outcome, and a lower risk does not eliminate an outcome. Most of genetics lives somewhere in between those two extremes. And I think one of the biggest lessons we learn from identical twins is that genes are incredibly important, but they don't operate in isolation. They're constantly interacting with the rest of biology. So if you're an identical twin with Graves' disease, your twin may have an increased likelihood of developing the condition compared to someone without that family history. But it absolutely does not mean they have it. And it does not mean they will definitely develop it in the future. The fact that identical twins can have different health outcomes is one of the clearest examples we have that genetics influences health, but doesn't completely determine it. And as we're going to see in some of our upcoming questions, that idea comes up again and again throughout genetics. So thank you so much for your question. All right, let's take a look at question 2. Now, question 2 says, what environmental factors could influence blue eyes? I really like this question because I think it gets at something that comes up all the time in genetics. People often want to know where genetics ends and where environment begins. And honestly, that's one of the biggest questions in all of biology. So, before we talk about environmental factors, let's start with something important. Eye color is primarily influenced by genetics. If you look at a room full of people, one of the reasons some people have blue eyes, some have brown eyes, some have green eyes, and some have hazel eyes is because of differences in the genes involved in pigmentation. So, in other words, genes play a major role in determining the amount and distribution of a pigment called melanin in the iris. The iris is the colored part of the eye, and generally speaking, more melanin tends to be associated with darker eye colors, while less melanin is associated with lighter eye colors such as blue eyes. One thing I want to point out right away is that eye color is actually more complicated than many of us learned in school. You may have learned a simple version where brown eyes are dominant, blue eyes are recessive, and that's the whole story. And that model can be useful as an introduction, but the reality is more complex. Multiple genes contribute to eye color, and those genes interact with one another. That's one reason eye color doesn't always follow the simple patterns that we expect. For example, sometimes two brown eyed parents can have a blue eyed child. Sometimes eye color falls somewhere between the categories. Sometimes it's difficult to predict exactly what eye color a child will have, and we just know that human genetics loves complexity. And eye color is a great example of that. Now, let's get to the environmental part of the question. Can environmental factors influence blue eyes? The answer is yes, but probably not in the way many people imagine. Because when people ask this question, they're often wondering whether environmental factors can fundamentally change the eye color they are born with. And for most people, the answer is no. The environment generally doesn't turn naturally brown eyes into blue eyes or vice versa. Our genetic blueprint plays a major role in establishing eye color. Now, if we're talking about actual biological changes in eye color due to the environment, there are a few examples where external factors can play a role, though genetics does do most of the work. So, one example involves certain medications. Some medications used to treat glaucoma, particularly prostaglandin analogs such as latanoprost, have been associated with increased melanin production in the iris. Over time, some individuals develop darker eye pigmentation, especially if they have mixed color eyes like hazel or green brown eyes. In some cases, that change can be permanent. Another example involves injury to the eye. Trauma can sometimes damage pigment producing cells or alter the structure of the iris. Depending on what happens, an eye may become lighter or darker than it was previously. This isn't common, but it can occur. Inflammation can also affect pigmentation. Certain inflammatory eye conditions, including some forms of uveitis, may alter iris pigmentation over time. And again, we're not talking about someone waking up with bright blue eyes after an infection. These are usually subtle medical changes that occur over time and are often accompanied by other symptoms. There are also rare examples involving chemical exposures. Certain industrial chemicals have been associated with changes in pigmentation elsewhere in the body, and severe chemical injury to the eye can potentially alter iris appearance through tissue damage. However, this is not something we typically think of as a common cause of eye color change in the general population. Now, there are also situations where the appearance of eye color can change. One of the most common examples occurs during infancy. Many babies are born with lighter eyes than they will eventually have as adults. Parents sometimes notice that their baby's eyes appear blue, gray, or lighter in color shortly after birth. Then months later, the color begins to change. This happens because melanin production continues after birth. As more pigment accumulates in the iris, eye color can become darker. So if you've ever heard someone say, "My baby had blue eyes and then they turned brown," that's actually something we commonly see. And I think it's fascinating because it reminds us that development doesn't stop at birth. Our bodies continue changing after we're born. Now, what about adulthood? Can eye color change then? The answer is sometimes, although usually the changes are much more subtle. For example, aging can occasionally influence the appearance of eye color. Some people notice slight lightening or darkening over time. Usually, these changes are gradual and not dramatic. Most people aren't waking up one morning with completely different eye colors, but small shifts can occur. There are also certain medical conditions that can affect the appearance of the iris. In rare situations, a person may notice that one eye appears different from the other. Whenever a noticeable change in eye appearance occurs, that's something worth discussing with an eye care professional. Not because it automatically means something serious is going on, but because changes in the eye deserve attention. And again, these changes are relatively uncommon, but they remind us that biology is dynamic. The body is constantly responding to internal and external influences. And now let's talk about one of my favorite misconceptions: sunlight. This is an interesting one because ultraviolet radiation clearly affects pigmentation in other parts of the body. For example, UV exposure can stimulate melanin production in the skin and contribute to tanning. Scientists have investigated whether sunlight can similarly influence iris pigmentation, but in healthy individuals, there is little evidence that normal UV exposure causes major changes in eye color. The iris appears to be much more genetically stable than the skin in that regard. So the answer is not really. Now, sunlight can influence how eye color appears. For example, lighting conditions can make blue eyes seem brighter or darker. The same person's eyes may look dramatically different in different photographs. Sometimes an eye color that looks gray indoors appears bright blue outside, but that's usually a change in appearance, not a change in the underlying eye color itself. I think we've all experienced this. You see someone's driver's license photo and then meet them in person and think, wow, their eyes look completely different. Often, that's because lighting changes how we perceive color, not because the actual pigmentation changed. Another thing that fascinates me is that blue eyes aren't really blue in the same way a blue shirt is blue. And I know that sounds a bit strange, but stay with me for a second. When you look at a blue shirt, you're seeing blue pigments. Now, blue eyes work differently. Blue eyes contain relatively little melanin. The blue appearance is largely the result of how light scatters within the structures of the iris. In other words, the color we perceive isn't simply coming from blue pigment sitting in the eye. It's the result of physics interacting with biology. It means that every time you look into someone's blue eyes, you're seeing a combination of genetics, anatomy, pigmentation, and light all working together. Now let's bring this back to genetics, because one thing I never want people to take away from discussions like this is this idea that genetics and environment are competing against each other. Biology doesn't really work that way, as our genes and the environment are constantly interacting. Genes help establish the framework. Environment influences how that framework is expressed. Sometimes genetics is the dominant factor. Sometimes environmental influences play a larger role. Usually, it's a combination of both, and eye color is a good example of that relationship. Your genes do much of the heavy lifting when it comes to determining eye color. That's why eye color tends to run in families. That's why ancestry can influence eye color frequencies within populations. But environmental and biological factors can still influence appearance in certain situations. So, if we're specifically talking about blue eyes, the biggest takeaway is this: blue eyes are primarily genetic. Environmental factors can sometimes influence how eye color appears, how it changes over time, or how we perceive it. But for most people, the reason they have blue eyes in the first place is largely rooted in genetics. All right, it's time for question 3. Question 3 says, can type 1 diabetes be DNA linked? The short answer is yes. Type 1 diabetes absolutely has a genetic component, but the more interesting answer is understanding what that actually means. When people hear that something is genetic, they often imagine one of two extremes. They either think if it's genetic, then it's completely determined by DNA, or they think if it's not guaranteed, then genetics must not matter very much. And type 1 diabetes is actually a really good example of why both of those ideas are oversimplifications. So let's start with what type 1 diabetes actually is. Type 1 diabetes is an autoimmune condition. So, like I mentioned earlier, that means the immune system, which normally helps protect us from infections and other threats, mistakenly attacks part of the body's own tissues. In type 1 diabetes, the immune system targets insulin producing cells in the pancreas. These cells are called beta cells. Insulin is a hormone that helps move glucose from the bloodstream into cells where it can be used for energy. When those insulin producing cells are damaged, the body can no longer make enough insulin to regulate blood sugar effectively. As a result, blood glucose levels rise. Now, one thing I want to mention right away is that type 1 diabetes is different from type 2 diabetes. And I think that's important because people often hear the word diabetes and assume we're talking about one condition. But type 1 and type 2 diabetes are different diseases with different underlying causes. Unfortunately, people with type 1 diabetes are sometimes faced with misconceptions about their diagnosis. One of the most common misconceptions is that type 1 diabetes happens because someone ate too much sugar. But that's not how type 1 diabetes works. It's an autoimmune disease. So it's not caused by eating candy, it's not caused by eating dessert, it's not caused by a lack of willpower. And I think it's important to say that clearly because many people still encounter those misunderstandings. Now let's come back to the genetics question. How do we know type 1 diabetes has a genetic component? One of the biggest clues comes from families. If genetics played no role, we wouldn't expect to see increased rates among biological relatives. But we do. People who have a close biological relative with type 1 diabetes generally have a higher risk than someone in the general population. Another clue comes from twin studies. And this actually connects nicely to the question we just talked about. Remember how we discussed identical twins and Graves' disease? Researchers have also studied identical twins in type 1 diabetes, and what they found is fascinating. If one identical twin has type 1 diabetes, the other twin has a much higher chance of developing it compared to someone in the general population. That tells us genetics matters, but here's the really important part. The concordance is not 100%. There are identical twins where one twin develops type 1 diabetes and the other doesn't. This observation tells us that genes influence risk, but genes do not completely determine outcomes. If DNA were the entire story, we would expect identical twins to always match, and they don't. So, what are the genes involved? The strongest genetic associations are found in a region of DNA called the HLA region. And the important thing to remember is what these genes do. Many of the genes in this region help the immune system distinguish between things that belong in the body and things that don't. In a sense, they're part of the immune system's identification process. Certain HLA variations are associated with a higher risk of developing type 1 diabetes. But having one of these genetic variants doesn't mean someone will definitely develop the disease. In fact, many people who carry these variants never develop type 1 diabetes at all. And that's where things start to get really interesting. Because if risk genes exist, and many people carry those risk genes without developing disease, then something else must be contributing to the story. And this is where researchers begin talking about environmental factors and triggers. Scientists have identified a number of possibilities that may contribute to disease development in susceptible individuals. They've also studied viral infections, early immune system development. They've even studied gut microbiome differences, dietary exposures, vitamin D levels, so all sorts of different factors. But despite decades of research, there is no single environmental trigger that explains every case of type 1 diabetes. And honestly, I think that's an important lesson in itself. Sometimes people assume that if scientists haven't found the answer yet, it must mean no one's looking. But trust me, people are looking. Type 1 diabetes is one of the most heavily studied autoimmune diseases in the world. And researchers have devoted enormous effort to understanding why it develops. We've learned a tremendous amount, but there are still unanswered questions. And that's one of the realities of science. Sometimes the honest answer is, We know part of the story, but not all of it. Now, one thing I find fascinating is that the disease process often begins long before symptoms appear. When most people think about type 1 diabetes, they think about the moment someone receives the diagnosis. But biologically, things may have been happening for months or even years before that point. In some individuals, the immune system begins producing autoantibodies long before blood sugar problems develop. These autoantibodies can serve as markers that the immune system has started targeting the pancreas. And this has opened up an entire area of research focused on early detection. Today, there are programs that screen certain individuals for diabetes related autoantibodies before symptoms develop. The goal isn't necessarily to prevent every case, we're not there yet. But identifying people earlier can sometimes reduce the risk of severe complications at diagnosis and may create opportunities for earlier intervention. And I think this is a really exciting area of medicine because it reflects a shift in how we think about disease. Instead of waiting for symptoms to appear, researchers are increasingly trying to understand disease processes before symptoms begin. Now, coming back to the original question, if someone asks, can type 1 diabetes be DNA linked? The answer is absolutely yes. There are genetic factors that influence susceptibility. There are specific genes that have been associated with increased risk. Family history matters, and twin studies support a genetic contribution. But as I've been saying throughout this podcast, DNA is not the entire story, and I think that's the most important takeaway. Again, sometimes people hear the word genetic and think inevitable. Those words are not interchangeable. A genetic influence is not the same thing as genetic certainty. Someone can carry risk associated genetic variants and never develop type 1 diabetes. Someone can have a family history and never develop type 1 diabetes. And at the same time, someone with no known family history can still develop the condition. Biology is rarely as simple as a single gene causing a single outcome. More often, what we see is an interaction between genetics, the immune system, environmental factors, and chance. And honestly, I think type 1 diabetes is one of the clearest examples of that principle. The genes matter, the environment matters, the immune system matters, and all of those pieces interact in ways we're still working to fully understand. So, yes, type 1 diabetes can be linked to DNA, but DNA is not destiny. Lastly, let's take a look at question 4. Question 4 states, "Hi, I was wondering what role genetic counseling plays for people who don't have a known genetic condition in their family." I really like this question because I think it asks something very practical. Because realistically, most people did not wake up one morning and think, you know what I should do today? I should go see a genetic counselor. Most people don't even know genetic counseling exists until something happens that brings genetics into their life. And that something does not always have to be a known genetic condition in the family. In fact, for many people, the first time they ever hear about genetic counseling is not because they already know a condition runs in their family. It's because a test result comes back unexpectedly, or a pregnancy screening result raises a question, or maybe a baby has an abnormal newborn screen, or someone has been trying to have a child for a long time and their care team starts talking about embryo testing, or a doctor notices a pattern in the medical history that no one had previously connected. So I think the most realistic answer is this. Genetic counseling often becomes relevant when genetics becomes part of someone's medical care, even if they had no known family history before that moment. And I want to emphasize that because I think it's important. A person does not have to walk into the appointment already knowing what the genetic issue is. Sometimes the whole reason for the appointment is that nobody knows yet. Let's start with newborn screening because I think this is one of the clearest examples. In the United States, babies usually have newborn screening shortly after birth. And this screening looks for certain serious conditions where early treatment or early intervention can make a major difference. Most babies who undergo newborn screening look completely healthy. Their parents may have had no concerns during pregnancy. There may be no known genetic condition in the family. No one is expecting anything unusual. Then the family gets a phone call saying the newborn screen was out of range. Abnormal, positive, flagged, and suddenly genetics is part of their life. That moment can be terrifying for families. Because when you hear that your newborn baby has an abnormal screen, it's very easy for your brain to jump immediately to the worst case scenario. But one of the first things a genetic counselor may help explain is the difference between a screening and a diagnostic test. A screen isn't the same thing as a diagnosis. A newborn screen is designed to identify babies who may be at higher risk and need follow up testing. It doesn't always mean the baby definitely has a condition. Sometimes the follow up testing confirms the diagnosis. Sometimes it shows the baby is a carrier. Sometimes it shows the baby doesn't have the condition at all. And that distinction matters so much because families are often hearing these words during one of the most emotionally vulnerable times of their lives. They have a newborn, they're sleep deprived, they may be recovering from birth. They may be trying to feed the baby, learn the baby's cues, manage appointments, and adjust to a completely new life. And then suddenly, they're being told, we need more testing. That's a lot to take in. So, in that setting, genetic counseling is not just about explaining inheritance. It's about helping a family understand what the screen means, what it doesn't mean, what the next steps are, and why follow up testing matters. It may also involve explaining the condition being screened for, what symptoms doctors are watching for, whether treatment needs to start right away, whether other family members may need testing, and whether future pregnancies could have an increased chance of the same condition. Now let's pause there, because this is where people sometimes ask, how could this happen if no one in the family has the condition? And that brings us to a quick genetics refresher. Some conditions found through newborn screening are recessive. For a recessive condition, a child usually needs to inherit two non-working copies of a gene, one from each biological parent. The parents are often carriers. A carrier typically has one working copy and one non-working copy of the gene. And because that one working copy is usually enough for the body to function normally, carriers often have no symptoms. They may go their entire lives never knowing they're carriers. So a family can have no known history of a condition, no effective relatives, and still have a baby diagnosed with a recessive condition. Not because anyone missed something obvious, not because anyone did something wrong, but because carrier status can be completely hidden. That's one very real way genetic counseling enters a family's life. Not through known family history, but through a baby's screening result. Another realistic example is infertility or difficulty having children. Someone may not be thinking about genetics at all when they first start trying to conceive. They may go through months or years of negative pregnancy tests, repeated pregnancy losses, or even multiple IVF cycles. And at some point, genetics may enter the conversation. That might involve chromosome testing. It could involve carrier screening, testing pregnancy tissue after a miscarriage, or even pre-implantation genetic testing during IVF. And I want to talk about this carefully because I know reproductive genetics can be emotionally heavy. By the time someone is discussing IVF or embryo testing, they may already have been through so much, feeling exhausted, feeling like their body has failed them. They may be grieving losses that other people never even knew about. They may be trying to make very expensive, very emotional decisions with incomplete information. In that setting, genetic counseling can help slow things down. Not emotionally slow it down in the sense of delaying care, but slow down the information. What test is being offered? What question is that test trying to answer? What are the limitations? What might the results mean? what would the next decision be depending on the result? For example, preimplantation genetic testing is not one single thing. There is PGTM, which is used when there is a known single gene condition in the family or in the reproductive partners. There's PGTSR, which can be used when someone carries a structural chromosome rearrangement like a balanced translocation. And there's PGTA, which screens embryos for chromosome number differences. Each of these are different tests with very different purposes. And this is exactly the kind of situation where genetic counseling can be helpful, because from the outside, someone may just hear, they're testing my embryos. But the details matter. Again, what are they testing for? How reliable is that result? What does a normal result mean, and what does an abnormal result mean? Could there be something like mosaicism, and what even is that? Could results be uncertain? Does testing improve the chance of a live birth in the specific situation? Or is it being offered more as an optional tool with limitations? These aren't simple questions, and they aren't questions people should have to figure out alone while already under the stress of infertility treatment. So again, this is a situation where someone may not have a known genetic condition in the family, but genetics becomes relevant because of what's happening clinically. Another common entry point is prenatal screening. Someone may be pregnant, everything may seem routine, and then a screening result comes back saying there is an increased chance for a chromosome condition. Maybe you had a cell-free DNA screening, or maybe a first trimester screen. Maybe there's an ultrasound finding, and suddenly the person is referred to genetic counseling. That doesn't necessarily mean the fetus has a genetic condition. It means there's information that needs to be interpreted. And interpretation is really important because screening results can be confusing. People may hear high risk and think it means diagnosis. They may hear positive and think it means definite. They may hear low risk and think it means impossible. But screening rarely works in absolutes. A genetic counselor can help explain what the result actually means, what diagnostic testing options exist, and what information each option can or cannot provide. And just as importantly, genetic counseling can support the person or family while they decide what they want to do next. Some people want every available piece of information, while others don't. Some people want diagnostic testing, and some people decline. Some people need time, and some people know right away. There is not one correct emotional response to genetic risk in pregnancy, and there's not one correct decision for every family. The role of genetic counseling is not to push someone toward a particular path, but to help them understand the information clearly enough to make a decision that aligns with their values. Cancer genetics is another example. Someone might say, well, I don't have a known genetic condition in my family, but maybe their doctor notices that several relatives had cancer at young ages. Maybe one relative had ovarian cancer, or pancreatic cancer, maybe metastatic prostate cancer, or multiple primary cancers. The family may never have called that a genetic condition. They may have just said, we have a lot of cancer in the family. And sometimes that's exactly how hereditary cancer risk first comes to attention. The role of the genetic counselor is to look at the pattern. We're basically like detectives. We're looking at what types of cancers are we seeing? What ages are these individuals being diagnosed? Which side of the family are these cancers appearing on? And how are people related? Has anyone in the family had genetic testing before? Is there a person in the family who would be the best person to test first? And again, testing is not always the answer. Sometimes the family history does not strongly suggest a hereditary cancer syndrome. But other times, testing is appropriate. Sometimes testing an affective relative would be more informative than testing the person sitting in front of us. Sometimes a negative result is reassuring, while other times it's not fully informative because no affected relative has been tested. This is why genetic counseling is not just order the test. It's figuring out which question we're trying to answer and whether a test can actually answer it. Another entry point is an unexplained medical finding. A person may not know of any genetic condition in the family, but maybe they have hearing loss at a young age, or cardiomyopathy, a history of fainting with concern for an inherited arrhythmia, a child with developmental delay, or autism with additional medical features. Maybe the doctor's seen multiple congenital differences, or a rare tumor, or a pattern of symptoms that several specialists have not been able to explain. In those situations, genetic counseling may be part of a larger diagnostic process. The family history may be completely negative, and still, genetics may be relevant, because not all genetic conditions are inherited from a parent. Some are caused by a new genetic change that happened for the first time in that individual, and we call that de novo. De novo just means new. So a child can have a genetic condition even when neither parent has it. An adult can have a genetic diagnosis even when nobody else in the family has been diagnosed. That is another reason the phrase, "it doesn't run in my family," can be misleading. It may not run in the family, but it can still be genetic. And that's a really important distinction. Genetic and inherited are related words, but they're not identical. All inherited conditions are genetic, but not all genetic conditions are inherited. So when someone asks what role genetic counseling plays for people without a known genetic condition in the family, I think the answer is genetic counseling often helps people make sense of the moment when genetics unexpectedly becomes relevant, whether that be through a newborn screen, a pregnancy screen, an infertility workup, a cancer pattern, a child's developmental evaluation, an unexplained medical condition, a genetic test result ordered by another provider. These are often the doorways, not random curiosity, not because people already know what to ask for, but because something in their healthcare journey raises a genetic question. And once that question exists, genetic counseling helps translate it. We help figure out what this result means, what it doesn't mean, what testing is available, what are the limits of that testing, who else in the family could be affected, is it inherited, and could it happen again? Does this change the person's medical care, change reproductive options? Does it change anything at all? Sometimes the answer to those questions is yes. Sometimes the answer is no. And sometimes the answer is we need more information. And that last one can be frustrating, but it's also very real. Genetics is powerful, but it's not magic. It doesn't answer every question, it doesn't predict every outcome, and it doesn't replace the rest of medicine. What it can do is add another layer of information, and when that information is interpreted carefully, it can be incredibly helpful. So, no, most people without a known family history are not just going to seek out a genetic counselor for no reason. It's not realistic. But many people first learn about genetic counseling because something unexpected happens. And in that moment, the role of the genetic counselor is to help turn confusing genetic information into something understandable, usable, and less overwhelming. Because for a lot of families, genetics does not enter their life as a textbook lesson. It enters as a phone call, a result, a referral, a question they didn't know they were supposed to ask. And genetic counseling helps them figure out what comes next. And this brings us to the end of another episode of Ask a Genetic Counselor. Thank you so much for spending part of your day with me. Whether you're a patient, a family member, a healthcare provider, a student, someone considering a career in genetics, or just somebody who enjoys learning about the human body and how it works, I would absolutely love to hear from you. So please, if you have any questions, feel free to leave them in the comments of the podcast. And remember, there is no question off limits. If you're nervous about posting publicly, know that you can create an account that's anonymous and submit a question that way. And if you enjoyed today's episode, please consider subscribing, leaving a comment, or even just sharing the podcast with someone who you think might find it helpful. And for those watching on YouTube, I especially would love to hear what topics you'd like to see covered in future episodes. Thank you again for being here. And until next time, keep asking those questions, keep staying curious, and remember that understanding your genetics doesn't mean predicting your future. It means giving yourself more information to navigate it. I'll see you next time in our next episode of Ask a Genetic Counselor.
Got questions about your genes or your DNA? Let's find the answers. Ask a genetic counselor.